Thank you, Dr. Lester, for that excellent presentation. I would like to introduce our next speaker, Dr. Mary DeJoseph. She will be speaking on fetal alcohol spectrum disorder 101. Dr. Mary DeJoseph works with the New Jersey Northeast FASD Education and Research Center is an adjunct faculty member at the Philadelphia College of Osteopathic Medicine. She is licensed in family medicine in Pennsylvania with clinical practice experience in general practice and geriatrics. She serves on the New Jersey and Philadelphia Task Force on Fetal Alcohol Spectrum Disorders and served on the National FAS-FAE Task Force. She is listed as author on the CDC and National Task Force publication Preventing Alcohol-Exposed Pregnancies. She consults with the Mental Health Association in New Jersey and does workshops on a variety of addiction and mental health topics. She is currently on SAMHSA's FASD Center for Excellent Expert Panel, the New Jersey Governor's Council for Prevention of Developmental Disabilities, and the Citizens Advisory Council to the New Jersey Division of Addiction Services. Dr. DeJoseph recently received an Ambassador Award in the area of healthcare from the New Jersey Governor's Council on Mental Health Stigma. Dr. DeJoseph is a member and a regional coordinator in the SAMHSA's Birth Mothers Network. Help me welcome Dr. DeJoseph.
Thank you. Okay, good morning. Can everybody hear me? Yeah, okay. Oh, good. Wonderful. Thanks so much for the invite to come here to Utah. I consider it a privilege. Our weather in New Jersey is raining and 60s and 70s, so it was great to get off the plane and have it be 90. And I have no financial or commercial interest in any of the items that are included. I work with the SAMHSA's FASD Center of Excellence, but that's not a financial interest. All right, and Dr. Adebato and many of the researchers, the work that you'll see on the slides, have given me updates ahead of time on their research and some non-published things, so I just wanted to thank them ahead of time also. Very difficult to do an update in 25 minutes, because I wanted to make sure when I was designing the slides that those of you who have no experience or knowledge previously about perinatal addictions and fetal alcohol syndrome, fetal alcohol spectrum disorders, I wanted to try and do a background slide and then an update to what we do now, all right? Fetal alcohol syndrome was named originally in this country in 1973. Work on prenatal use of alcohol certainly proceeded long before that, but that's when the terminology began. Ken Jones and David Smith coined the term fetal alcohol syndrome in 1973 based on a study of 8 newborns who had similar facial features and growth delay. There are 3 things that you needed for diagnosis and still do. A constellation of facial features, growth delay, and brain dysfunction. If you have those 3, they're specific enough that you don't need maternal history. If you don't have all 3 of them, you need to try by whatever means to get a history of drinking during pregnancy. 2005, a number of federal agencies got together and they said this autism spectrum disorder, the spectrum concept worked for the autism community. Let's apply it to the fetal alcohol syndrome and to fetal alcohol spectrum disorders. So if you send a newborn child, adolescent, or an adult for fetal alcohol spectrum disorders evaluation, it may include partial fetal alcohol syndrome, the older term fetal alcohol effects, some of you will remember, the American Academy of Pediatrics terms alcohol-related neurodevelopmental disorders or alcohol-related birth defects. FASD is an umbrella term. So it's not a diagnosis. There's no ICD-9 code. You can't put it on your chart and bill for it. It covers the spectrum of effects for any person who has been exposed to alcohol prenatally, FASDs, all right? Facial features. Classically, 3 different classification systems for fetal alcohol syndrome. The 4-digit code from the University of Washington. CDC has a system. Institute of Medicine has a system. And there's a table out around the corner from the Utah Division of Substance Abuse and Mental Health, and they have all of this information and background. They have the CDC curriculum, so stop there if you're interested. Historically, we had a Gestalt diagnosis, so we as physicians looked at the face and got an overall impression of facial features and dysmorphology. And that's still used in many areas of the world, all right? The 4-digit code allowed them to develop hardware and software so that they could analyze photographs. So they would look at 3 features: the palpebral fissure length, the philtrum, whether it was flattened or full, and the thickness of the upper lip. So short palpebral fissures, flattened philtrum, and thin upper lip were historically the 3 facial features, and they're still used today mostly by computer-analyzed photography. Now, however, they're taking 3D imaging technology that's used for a whole variety of things, and they do laser scanning of the face, so they not only analyze the width and length of various facial features, but also the depth, and the colors tell you where things in the alcohol-exposed youngster are different from their typically developing counterpart. This was also, I thought, oh my goodness, I'm going to a dermatology conference. I better check and see if there's research on prenatal alcohol exposure and the skin. And oddly enough, this is a study by Ken Jones, the original Lancet author from 1973. And he finds a difference from 0.3% in his control population of the port wine stain to 14% in youngsters who are alcohol exposed. It is not diagnostic, but it may be a supportive finding, all right, for those of you who are dermatologists, to look more closely at some other historical features. Other updates in epidemiology. The CDC in 2002 and 2005 we're reporting out numbers, incidence numbers of 0.5 to 2 per 1,000 for people diagnosed with fetal alcohol syndrome, and they were under the age of 18. All right. Now there's an international consortium. The main studies are in the West Cape of South Africa, Finland, Italy, France, and with the Plains Indians, but also in a variety of other places. There's also a big consortium in Canada, and they're ahead of us in their screening and surveillance. The numbers that are being reported now in school studies, so they screen whole school populations, are almost 10 times that, rather than 0.2, up to 5 to 7 per 1,000. We used to say 0.2 per 1,000, all right? South Africa, the West Cape of South Africa is still reported to have the highest incidence, 70 to 90 per 1,000 incidence of full fetal alcohol syndrome, where they are still paying mothers partially that are working in the old DOP system, and some of their wages are given to them in the dregs of the wine. In some of those vineyards in South Africa. Croatia, the studies are about, are close to the United States and in around 4%. And as we look at binge drinking worldwide, this continues to be a global problem. Ireland still gets the prize for the highest rates of binge drinking. And from someone whose maiden name is Mary Catherine Patricia Curran, I can identify with that. And Canada looks at surveillance and what the needs, the physician and healthcare needs of their children are, and find that children that are prenatally alcohol exposed, not surprisingly, are more likely to see a doctor, require medication, and end up hospitalized, all right? Their estimates are $7.6 billion per year in Canadian dollars for the care of people that are prenatally alcohol exposed. 2004, the last comprehensive study was published by the Lewin Group here in the United States, and they estimated $6 billion a year in this country. All right, so we have to look at prevention, and thank goodness to follow Rosemary's excellent overview of contraceptions, because CDC is running a study right now called the Choices Program. They also do Choices Plus, and they say, with this cost in healthcare and in financial resources and in suffering, the most important thing that we can do is prevent the fetal alcohol spectrum disorders. And that requires us to educate patients about, the risks of drinking during pregnancy. It's a highly inflammatory topic. Fortunately, we don't have time to get into a debate about it. But what we can say is that on the last CDC estimates, that 53 to 54% of pregnancies in America are unplanned. If you look at the population of women who have ever been incarcerated, that's over 80% of unplanned pregnancies. The highest risk populations for women to have a child who is alcohol exposed with fetal alcohol effects are those who have evidence of alcohol abuse and dependence, who have ever been treated for alcoholism, who have ever been incarcerated. So those are the populations, if you look at prevention, that tend to be targeted for selective prevention. One of the things you do as you look at primary prevention, though, is look at the role of the media in selling alcohol to women. All right, the history started in 1959 with ads that targeted women from Budweiser, and you can see that where there's life, there's Bud. All right. Now we've gotten a little more sophisticated in these pictures there on the left, still targeting younger women. And then there's some backlash from a variety of women's groups toward this sort of media advertising. But women respond, if you survey attitudes toward drinking and drinking during pregnancy amongst women, they are highly influenced by the media. All right? Phil May in 2010 revised what we considered the maternal risk factors. We know some women will be able to drink alcoholically during pregnancy and have typically developing newborns. Others can binge 3 or 4 times and have youngsters who are profoundly affected. So there's a variety of factors that say which fetuses are going to be more vulnerable to the effects of prenatal alcohol exposure, and these are some of them, all right? Blood alcohol level, but more importantly, the pattern of drinking. So binge drinking puts the fetus at higher risk for effects than 7 drinks on Friday night is more dangerous than 1 drink a day, all right? And a quarter of Americans are still reported to binge drink. Timing, there can be effects all through all 3 trimesters. Advanced age, obstetricians are giving the calling 30 an advanced age for pregnancy. That's just horrifying to me, but older women, actually the highest slope for increase in drinking during pregnancy is Caucasian women over the age of 35. You know what happens? We tend to have hotshot careers, drink to medicate our stress at the end of the day, and then when you become pregnant for the first time at 35 or 37 and try to stop drinking, you may find that it's a problem. So that's a high risk, considered a high risk population. Not the highest risk for numbers, but the steepest slope. Genetic sensitivity and epigenetic factors, we'll talk about epigenetics. Nutrition is an intense field of research right now. As those of you who are obstetricians know, some of the effects of prenatal alcohol can be ameliorated with a variety of nutritional supplements, and we'll get to a slide on that. Synergy with other agents is an important thing because this is one of our biggest barriers. Women will come into the primary, I'm a general practitioner, into a primary care office, and want to argue and have a discussion about this, drinking alcohol during pregnancy, and my obstetrician says a little wine is okay, and so on. And one of their arguments is, well, my mom drank when she was pregnant with me, and sometimes you look at them and say, yep, her. I don't go there. But I think in 1959, when my mother was pregnant with me, she lived on a different planet than my daughter will when she's pregnant, just because the burden of fertilizers and pesticides and heavy metals and other neurotoxic agents that have to, be dealt with by both the mother and the fetus. So that's a significant barrier because of the grain of truth in it. Mental health issues and supports, as you know, we're starting to get more and more information about the effects of unidentified, untreated mental illness during pregnancy on both mother and fetus. Epigenetics, hundreds of new articles if you do an update on perinatal addictions and specifically alcohol. These are changes to DNA, methylation changes specifically to chromatin that don't change your DNA sequencing, but they do affect how genes are expressed. So this is This is the way to understand how a variety of environmental factors can affect which fetuses are most vulnerable to be born with one of the fetal alcohol spectrum disorders. And these are some of the other risks, and here's how we used to present risks to the fetus by trimester in a variety of really general ways. And now they're being able to zero in on much more specific risks to neurotransmitters, not just cell damage and neurotransmitters, but specifically GABA and serotonin and dopamine pathways. And this will explain some of the effects that you see in affected youngsters on learning, memory, and mood. Higher rates of seizures with prenatal alcohol exposure than were originally reported. And there's a prenatal alcohol SIDS and stillbirth study that's ongoing that is discussing some of the higher rates, especially of SIDS in babies, infants and babies that are alcohol exposed. All right, neurobehavioral profile. So Sarah Mattson and her group in San Diego have looked at a variety of neuropsychological profiles, because we can look at faces and we can look at growth delay, but it's really in the brain dysfunction that so much of the real cost of this problem comes out. And problem domains are the 11 that are listed, and you'll have access to the slides and so on. Sarah Mattson narrowed that down in her study to the ones that were most, the biggest problem details were executive functioning and spatial processing. So this is an international group from the International Coordinating Committee on Fetal Alcohol Syndrome that gets together and says we need a behavioral phenotype to start identifying these youngsters, and they're starting to be able to design that from studies from Mattson and her group. And these are some of the other research updates. There's a variety of neurobehavioral alterations. 96% of youngsters that are diagnosed with fetal alcohol syndrome will have either a co-occurring or a primary ADHD along with their FASD. And now we're starting to be able to say, well, how do we know if it's primary ADHD or if it's an FASD? And they're starting to be able to break down ADD and ADHD to, do you have problem gathering and encoding information or retrieving and using it later? So Claire Coles and her group in Atlanta at Emory are zeroing in on some of those. So what are we going to do about it? Because women continue to drink during pregnancy. The vast majority of women will stop drinking once they find out that they're pregnant. 86%, 87% of them will stop drinking when they find out that they're pregnant. But depending on what that is, that still puts your developing fetus at risk during that first trimester. So what can we do about the women who don't find out until they're pregnant, that they're pregnant until later, or women who, there's a variety of categories who don't believe that alcohol is a problem, or maybe would like to stop drinking and aren't identified as alcohol abusers, and treated appropriately. These are some of the interventions, both prenatal and postnatal, that we're starting to find out may make a difference developmentally. And you can look at interventions either at mechanisms of damage, so those tend to be nutritional and pharmacologic, or ones that enhance neuroplasticity, environmental things especially, and behavioral. So some of the both pre and postnatal things, supplements that you can do are in the whole nutritional realm, reported as having cause and effect improvement in animal studies now, are things that you can get in prenatal vitamins. Zinc, one study also reported selenium to make a difference, antioxidants C and E, and folate. Jennifer Thomas has done a whole series of studies on choline as a supplement. Now you're starting to see choline being added to children's cereals, so it's not useful just for prenatal alcohol. But both prenatally and postnatally, choline supplementation can make a difference in coordination, memory, and some aspects of learning. So you can either buy it as a supplement at Whole Foods or GNC, or get it naturally through the diet, eggs, nuts, and so on. All right. And here are some other behavioral interventions. The first group, through Families Moving Forward, are ongoing studies by the CDC for behavioral interventions. in a whole variety of areas, and all of them are past the laboratory stage and being tested out in clinics in a variety of communities. And they've targeted a bunch of different areas. So Project Buddy says that if you can use mentoring and social skills, you can actually improve the outcome of young people with a fetal alcohol spectrum disorder. Remember, they have executive functioning problems. 10% of them will have an IQ less than 70. The other 90% don't. They tend to be found in much higher rates in the juvenile justice system. Alarming numbers come out of criminal justice system because they grow up, and if they're not identified, they tend to have high levels of impulsivity and attention problems. So they have a thought and then they act on it, all right? And if you're somebody who's alcohol exposed and you've grown up in an alcoholic family, you're at triple jeopardy, all right? You may still be living with an alcoholic parent. You have the genetics to develop alcoholism, and you have poor decision-making capability because of alcohol-associated brain damage. So they tend to be youngsters that start getting into trouble early and stay in trouble. All right. Ann Streisiguth did ongoing studies of 450 people from the ages of 9 to 52, and she followed them over 20 years. She published her results in 1998 and again in 2004, and she's pending one more follow-up study. And she says the secondary disabilities tend to be just about the same. Primary disabilities are those that result from brain damage. So they are executive functioning problems and learning problems, coordination, perhaps cognition, activity and attention. Those are all primary disabilities that need to be accommodated. If you don't identify those youngsters, and they can go on to develop secondary disabilities, people are more likely to be institutionalized in either jail or mental health or addiction treatment centers. They have trouble with the law, they have disrupted school experience. They tend to have, 49% of them will have inappropriate sexual behavior. They have a variety of co-occurring issues like joblessness, homelessness, victimization, difficulty parenting, and so on. So these are some of the interventions that have been shown to work in young people. These are in 9-year-olds before they go on to develop those devastating secondary disabilities. All right, social skills training pairs youngsters up, teaches them how to insert themselves into social situations, deals with social anxiety. It's a fascinating program to watch, and it's also applicable to young people with high-functioning autism and Asperger's. The sociocognitive habilitation, math interactive learning. So people that are alcohol exposed, one of their primary disabilities tends to be in math. So they have trouble with time, they have trouble with managing money. And this group says, at the Marcus Institute, says they deal with learning readiness and with parent training. So skills that are good really for any childhood disability have had some success, all right? Neurocognitive habilitation does some sensory integration therapy, and that is life-changing, all right? Parent-child interactive and families moving forward both focus on parent training and family interactions and how to deal with these youngsters. The other ones, these are that last group. Parent-Child Assistance Program, PCAP, in Washington, and it's also being piloted at a number of sites, actually nationwide. This is a prevention program. So they deal with high-risk mothers long-term in preventing pregnancy and preventing drinking during pregnancy. All right, you can prevent an alcohol-exposed pregnancy either way. All right. So they take high-risk mothers and put them into long-term treatment and do a variety of parenting classes and disabilities classes. And they also do high-level training and follow-up on appropriate and effective contraceptive methods. And I have to congratulate Rosemary for her whole contraceptive update is exactly what we're telling some of the women in the Choices program. If you're drinking or using drugs, you can't remember to take a pill every day, nor use a barrier method. So implantation methods and IUDs are something that has much higher success rate with this high-risk group of women. All right. Juvenile justice screening is a program in Colorado that's giving us our numbers of how many of the juveniles that are in detention centers have been alcohol exposed. You have to take their pictures anyway. So once you can get past, the permission forms, they can use the screenings to actually analyze facial features and get an idea about those numbers. Alaska is running a program on animal-assisted therapy, and like many other areas of children and adolescents and inmates with disabilities, working with animals is a significant boost therapeutically. Nutritional interventions and environmental stimulation at San Diego, they do frightening things to rats in barrels of water and in mazes, and to study learning and so on. And I have to thank those little creatures, because these are studies that give us tremendous information about what environmental factors really improve learning and memory and decision making in people whose brains have been damaged by alcohol and other substances. Neurofeedback and biofeedback is expensive and it's not available everywhere, but you can train youngsters, to look at how their brain works and pinpoint specific problem areas, and give them strategies to work with that. So if it's available to you, they're reporting high success rates. Skills training is stuff that we can do in primary care. So when you think of skills training in addiction treatment, it's all about anger management, right? Well, we'll send them the skills, we'll send them the anger management, and that'll take care of everything. And all the rest of the myths, if we help mom get better, that'll take care of her kids, all those things that we think. If we can get them sober today, everything will be fine. And skills training, actually, we're looking at on a much broader level, especially with women in treatment and women and children with treatment. And it includes medication skills and some reflective therapy, not just anger management, and ongoing parenting skills and nutritional interventions, and pre-vocational, long-term pre-vocational and job training. So lots of new stuff in skills training. These are some of the recent research in journals and books, because I had to fly through all of this. I would recommend any of them. You have a whole lot of resources out on the table at your Division of Substance Abuse and mental health. And I understand that they are also piloting a program here in Utah to implement screening and brief intervention. And let me put my vote forward as a positive on that. The CDC reports in their screening and brief intervention studies that brief interventions work and motivational strategies work. I used to think, how could brief interventions work? They just report positive results because the grant's up in 3 years. But actually, over time, there's convincing data that brief interventions with women that are ambivalent about their drinking actually are very effective. And, we as doctors aren't reported to be very good at ongoing counseling, especially in nutritional and areas of substance abuse. But we certainly have impact to start on women with ambivalence. So, if you have an opportunity to be oriented to that screening and brief intervention study and participate, I would applaud any of you that do that. You can make a significant difference in people's lives. And that's it. I'm doing skills workshops here this afternoon, so we can do some specifics on FASD prevention and how to go about preventing alcohol-exposed pregnancies. And I thank you for your attention. We have time for questions. Okay. 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 Oh, I'm gonna keep this.
Well, I had a question for Dr. DeJoseph, and I was wondering if they know what exposure of alcohol, and it's probably variable, leads to fetal alcohol syndrome. And I know in the GI world, we can quantify at least, or get some idea of the alcohol exposure that causes liver disease. But what do we know about the amount of alcohol necessary to cause or increase the risk dramatically of FAS?
Right. Thanks for the question. I wish I had a specific answer to it. We do not have what is a safe threshold of how much alcohol is safe to drink during pregnancy, just because of the extreme variability in anyone in this room drinks, the 1.5 ounces of alcohol that's in a standard mixed drink will have a slightly different blood alcohol level. Women metabolize alcohol differently than men. Depending on the combination of maternal and fetal genetics, the acetaldehyde dehydrogenase will metabolize the alcohol differently in the fetus. So there's not reported a safe threshold. In some women can drink throughout their pregnancy and have typically developing infants and children. There's never zero risk. All right, so it's a gamble. It's a gamble. You may have a youngster who just has mild attention problems, or is typically developing, or just has a minor birth defect. But if you're one of the vulnerable fetuses and combinations, you can have lifespan problems. So ACOG and the American Academy of Pediatrics and CDC and the Surgeon General all still recommend to abstain from alcohol during pregnancy. And if you can't abstain, let's take a look and see if you have a different problem for us to talk about. All right. Oh, good. Okay, go ahead. Hi.
Well, if every time a pregnant woman gets in the car to go to the grocery store, her fetus is at risk.
Truth.
We obviously do not worry about risks below some threshold. And I have heard nothing about how much alcohol would be required to produce what sort of defects of what severity after the 4th month of pregnancy.
After the 4th month of pregnancy?
I have not heard of any evidence of damage to a fetus after the 4th month of pregnancy.
The brain and the spinal cord develop throughout the entire pregnancy, and there's some areas of the brain, including the corpus callosum, and areas of the basal ganglia that are vulnerable to alcohol effects that you can see changes in animal studies. Naturally, they're not in human studies. So there are some risks. There are effects of alcohol. Some of them may be repaired and some not. We certainly see ongoing activity and attention problems even in women that only drink heavily during the 3rd trimester. So there's a variety of small studies that give you effects after the 4th trimester. Those are reported in some of the 2011 books and journals on a broad scale. You're right, there's risks to all of us. Walking out the door, going to the airport terrifies me. But this is a preventable risk. I guess if you never got in a car, you could prevent car accidents. But this is something, given the quality of life and the quantity of life in people that are affected by prenatal alcohol exposure, given those problems, and given the fact that we don't know who's vulnerable and who isn't, I still advise women that this may be one of the risks that they want to avoid. It may be needless, but it's 9 months of, maybe needless abstinence. Others. Thanks for asking that question. I mean, that's the worry. That's the worry.
Of course,
Yes.
I've heard it said that a simple way of viewing fetal alcohol syndrome is that children are born without a conscience. Is there any truth in that brief analysis?
Children born without a conscience, they look like, if you have criminals either in the juvenile or the criminal justice system and you talk to them, they look remorseless, when you talk to them, they seem remorseless in some of their crimes. Sometimes that's a co-occurring psychiatric disorder. Sometimes it is the lack of empathy that people with fetal alcohol syndrome tend to have. They are very concrete people when you talk to them. So if they have to imagine the effect of a crime on someone else, they're often unable to do it. They can't imagine consequences. They have higher rates of suicide because they don't imagine consequences and they don't have a concept of time. But they can certainly look remorseless, and it's one of the most devastating consequences of fetal alcohol syndrome. And it's not all in grown men and women. You can have 9-year-olds that have high levels of aggression and violence and don't seem to be able to empathize with the victims of their attacks.
When you mentioned the almost prenatal, we always think of fetal alcohol syndrome in the mother, but when you said epigenetic changes in the parents, so are you suggesting that the male alcoholic partner could also lead to some FAS?
The studies on the fathers of, there's never been a reported case of fetal alcohol syndrome where only the father drank, all right? So we know that men who drink alcoholically have some effects on sperm. You know how the sperm turnover rate is. Epigenetic effects on sperm will have the same thing. So they can be affected by alcohol and by violence and by nutritional effects. So you can look at epigenetic effects in male sperm, but they're temporary. So you get to make a whole new batch of male sperm. It's hard to pin it down. If you have men that are drinking alcoholically long term, then the next batch of sperm is also affected. But that's where the
We
concentration
don't think it
on
comes
what
out
about the
in
father
the
effect.
fetus, like the mother.
Right, right. Mm-hmm. Yeah. Others. Thanks for your patience. I know everybody's not agreed on this issue. Okay.
Just a reminder, we're going to reconvene this morning's session at 10 o'clock in ballroom B through E. Remember to take with you everything that you brought with you into this room. The doors will be shut in preparation for our discussion at noon.